This is something which probably we don't talk about much, but becomes a very important thing in our day-to-day life. Dr. Ramdeep has kind of said on stage, he was speaking about addiction, and one of the offshoots of addiction is self-harm and suicide. So I'll keep it brief, but at the same time, I hope that after this session, we'll at least have a pledge to care for ourselves and for our community. So this is not an academic presentation. I would like to kind of make it more interactive, and I'll keep it brief because I know that we are running short of time. How many of you have heard about this phrase? Raise your hand. Nobody? It's a very common tattoo nowadays. Que custodian ipso custodis, which basically means who watches over the watchman. There was a spike of suicides among physicians at the time of COVID, a few years back. And even today, as India is often termed the Asian capital of suicide, one of the populations with highest death rate due to suicide is the physicians. For various factors, one of which is very clearly highlighted in this documentary. Anyone here have heard about this documentary or have seen this? If not, that's a homework for today. It's a brilliant, brief documentary which shows what specific factors in our lives push us to the edge, and one of which is a lack of peer compassion, which is very clearly shown here and pointed by some of my earlier speakers as well. Do we care to ask ourselves how we are and our colleagues as to how we are doing? I will not waste time on data, let's not make it theoretical, but there are various factors and reports which mention that the death rates, especially among medical students, are increasing. We all know the rising rates in the recent newspapers, especially as the entrance exams approach, the NET, the super specialty exams, and as a psychiatrist, I have several individuals who are my colleagues and my students or my juniors who approach telling that they face an immense amount of stress and they have nobody to talk to. So these three questions we need to ask ourselves right in the beginning. Do we care for ourselves beyond our identity as a physician? Do we have time to look around us? Today we have a gathering of so many people. Do we, after this, will we be congenial to each other's necessities? And can we see beyond the obvious? Suicide does not mean depression. Suicide does not mean psychosis. Suicide doesn't mean psychiatry. It is a lifestyle issue. It is a societal threat. It can even happen when a person fails to have a person to talk to. So equating suicide with depression that the media commonly does itself is a difficult thing. Three main drivers of suicide in healthcare workforce. One, stigma. And I will not shy here, even among psychiatrists, I have seen that my colleagues, they fail to talk about their own issues to us. I am treating a patient, fine. If something happens to me, I would rather keep it away. Second, access. Sometimes we don't feel free to talk to our team members or take professional help. And the easy access to medications that the doctors have. We have often heard about fentanyl, betadine being injected for self-harm, which is a very, very common practice, and job stressors not to mention. What are the warning signs? Now, when we talk about warning signs, it's not just a person feeling depressed. Let me go ahead a bit. This is a wonderful opinion that was published in the New York Times. Once again, a good read to understand what happens to us in our formative years. Let's come here. These are called the red flags. Of course, age is a factor. Previous attempt, substance use, rational thinking loss, which happens in psychosis, having an organized plan, having self-harm or multiple cuts on various parts of the body, and you see a sudden change in behavior. You see a person gradually getting withdrawn, somebody who was very jovial, very cheerful, just kind of gets separated, doesn't talk, doesn't share. You don't see him or her in rounds. That person doesn't join you for partying, probably has reduced drinking. Why? Do we bother to ask why? If we ask, they tell. If we don't, they don't say. And that is a very, very common practice among physicians. Also, one of the things that we commonly face is peer pressure, academic expectations, and in the formative years or in the years of medical education, a continuous societal outlook that you have to reach to at one point, which kind of raises on the top of our head. So, these are the specific risk factors. Family expectations, if somebody has an anxious personality, is isolated from the society for a long time, mental health conditions, the prime being depression, the second being an anxiety disorder, and the third being personality, especially borderline or cluster B type personality. Financial stresses, which are very, very important, and bullying during the time of your education. Trust me, bullying is not limited to engineering streams and students in other fields or in school or colleges. Bullying exists very much as we rise up in the profession as well. And professional bullying is one of the things which provokes a person to take away their own life, because all of us, everyone in this room has a line. If that gets crossed, no matter who you are, no matter how much you earn, no matter where you are in position, you will break. And we need to stop this breaking from happening. I repeat, suicidal thought or self-harm is not equal to mental illness. I can be perfectly psychologically fine in terms of a DSM or ICD diagnosis, yet I may be contemplating suicide even as I speak here. Now, how do we understand that? How often in our day-to-day conversation with our friend in OPD, in parties, even in conferences, do we ignore the relationship issues, debts, substance use, intimate partner violence, sexual abuse, academic problems, especially if somebody is a slow learner or has probably a borderline or an average IQ, adverse childhood experiences. When a person is in the early year of the medical education, what kind of family environment do they find? Trauma, easy access to various medications. Definitely lack of dedicated policing till a few years back when we as a country developed a national suicide prevention policy. And finally, sexual abuse and presence of substance use. Now, why talk about gatekeeper training? Now, these are the factors apart from mental health issues that are there. Socio-economic factors, environmental factors, legal factors. We had a session about multiple medical legal issues. I have faced, or many physicians have come to me telling that, this is burdening my head. I have this protector's guilt. Many of us are physicians. We kind of imbibe vicarious trauma, especially those in critical care, those in oncology who frequently see deaths, and you tend to be responsible for each death you see in front of your eyes. I remember my colleagues back at Nimhans telling me when there was COVID that I am not able to sleep at night because I have nightmares of that particular person on death table pointing their finger at me and telling, you as a doctor were not able to save me. But trust me, we all know that we do our best, but the best may not be enough. So if we continue to imbibe that, often that trauma can lead to suicidal thoughts. How often do we encourage to seek professional help? Just a brief question. How many of you here have encouraged your colleague to go to the psychiatrist or the psychologist? Can we have hands? I don't think it's only two, probably many of us. I hear a lot of colleagues sending to me or to other psychiatrists for this purpose. But ask yourself this question. Tomorrow, if you suddenly don't feel like living, will you visit a psychiatrist? If this question is answered, I think half of the gatekeeper training is done. Now, these are the key components. A gatekeeper training program needs a full day. I'm just giving you the key points. If you are talking to a person, a gatekeeper training need not happen in a big hall. It can happen over a cup of tea. It can happen over a chai karta. It can happen in your drawing room. It can happen while you are going for a long drive. You need to be direct, understanding, empathetic, and you need to connect the person to the right dots. If you ask somebody, how are you feeling? Nobody's going to tell you suddenly, oh, you know, I'm very depressed, I'm sad, I don't want to live. You probably need to bring the person into confidence and try to understand. Most of the times, trust me, when I have faced difficult times in life and I've gone to a physician friend, all that I've heard is, जाके एक पेग ले ले ठीक हो जाएगा, ओ जस्ट एक सुट्टा मार के ठीक हो जाएगा, ओ मन खराब का कुछ नहीं होता है, मन खराब का कुछ होना है. I know that we know what depression is, what stress is, but do we care to ask our colleagues if they are stressed and what do we do about it? This is the basic model for suicide prevention. It's a theoretical model. It's based on our knowledge about why suicide happens, beliefs and attitudes about how I can prevent, eliminating stigma, and finally the wish to intervene, that should I make a difference in somebody else's life. I think we all are gatekeepers here. Every single person, irrespective of their profession, every person in this hotel is a gatekeeper. Because you need not be a doctor to be that. I need to understand that when a person is thinking of ending their life, the person must really be at their edge. And also identify at-risk people. Not everybody in our MBBS batch was same. Some were introvert, some spoke less, some came less to us. Some probably couldn't grasp lessons well. Some had a history of a psychiatric condition. Some had history of family violence. If we don't seek them out, who will? And direct them to professional help as soon as possible. You know, gatekeeper training starts the first day a person enters MBBS, not after that. And then it's a process from there on. You need not be a psychiatrist, you need not have a lesson in psychiatry to understand that you need to be compassionate. And that compassion is not an intellectual compassion. The other person should feel that you are willing to understand what is going in that person's mind. And we know that we are a close group. We always work in teams, groups, rounds. So if there is a person, a resident, who is just not responding well that particular day, I'm sure many of the consultants will call them separately and tell everybody, what's happened, what's wrong, why you not your usual self? And many of us wait for that question because we are waiting to tell, but we don't have ears to tell. So, yeah, this is a thing I want to mention here because we often interact with media. And one of the things I often tell in suicide prevention is we need to write about suicide in a responsible manner. A person hanging from the ceiling or a person's hand or a person's pits are not something to be discussed of. Dignity needs to be mentioned. And there are certain clear do's and don'ts in the World Health Organization website about how you need to report a suicide, even when I'm writing or documenting, because every person that comes to us comes to hospital with an attempted or a completed death due to suicide is a potential medical legal case. So how I am documenting it needs to reflect the dignity of a person. A person does not become a case after suicide. It's a person who has died because probably the person didn't get help. I don't mean every person can be stopped, but research says that 70% of individuals who try to kill themselves have sought professional help in last 1 month. And do you remember these three individuals who were recently found hanging? Very recently, a man, a wife, and two children. When, the media people reached out to many of us and we were discussing, what we actually heard, I don't know whether it is true or not, is that the family had completely separated them from the society. And that was 2 weeks. And this gentleman who allegedly died due to suicide had actually mentioned to several of their close circles that, things are not getting fine. Thoughts are coming to my mind, but probably nobody took the step. So this is few do's and don'ts. I won't go into the detail of this. These are the support systems we can reach out to. There are several suicide helplines. National Institute of Mental Health and Neurosciences has one, collaborating with Ministry of Healthcare. There are resources and community networks in PGI, at NIMHANS, at AIMS Delhi, where we can reach out to. And this is one of our documents which we had published in Lancet before on suicide prevention strategy. Today we have a national suicide prevention strategy for India. And finally, at various levels, gatekeeper training is held from government resources, especially among students and faculty, so that they identify the people who are at risk. So yes, you are not alone, but let us end by asking ourselves this question. Do we really care? Yes, we do, because we are having a conference like this, but let's continue the care even beyond sessions. These are few books that you can have a quick read, including a very famous Robin Hood's book on Manner of Death, which talks about physician suicide. And these were fantastic documentaries which highlight how a doctor's life is fraught with several such moments when they think about ending their lives, but ultimately they bounce back. And my personal favorite, if anybody of you like 3 Days Grace, it's a band. They have this song on suicide prevention called It's Not Too Late, It's Never Too Late. And it is never too late to save a life. Happy Holi in advance to all of you, and that's all from my side. Thank you.
Thank you.